Okay, Assalamu alaikum everyone. My name is Hala Sammour. Ramadan Mubarak, first of all. My name is Hala Sammour. I'm a fourth year medical student, and today, inshallah, I'll be presenting you the OSPE section of your GIT course. Inshallah, in this session, we'll be covering. Mm, okay. Okay, so inshallah, in this session, we'll be covering the pictures that were covered in your patho, clinical, micro, and radiology lectures, alongside two of your lab medicine lectures, LFTs, and tumor markers of the GI tract. So how this session will go is that I won't only be showing you the pictures and the diagnosis, but I'll be giving you some bullet points about each picture. I thought maybe it would be a good review for your OSPE as well as for your MCQs, inshallah. So let's start with the upper GI tract or the esophagus. So first of all, we have the infectious esophagitis. Infectious esophagitis is basically an infection of the esophagus, and this is usually seen in immunocompromised patients. So you guys basically took three types: the one that is with Candida or a fungal type, and then the herpes simplex, and then the cytomegalovirus type. Starting off with the fungal one, which is the Candida. As you can see over here in the picture, the hyphae and the spores are very prominent. These are the spores, the dark dots, and the lines are the hyphae. So you could easily tell that this is a infectious esophagitis due to Candida. Next, we have the herpes simplex virus. As you can see over here, it's an intranuclear presentation. So the virus is intranuclear, and it is common to be seen as punched out ulcers. So this word is basically a buzzword to think about herpes simplex virus and infectious esophagitis. Here, on the other hand, we have the cytomegalovirus, which are seen as shallow ulcers. What you can see in this picture are the large intranuclear and intracytoplasmic inclusions. So here it's intracytoplasmic and cause shallow ulcers. Here they are intranuclear and they cause punched out ulcers. Next, we have the eosinophilic esophagitis. So here we have, it's a kind of inflammation of the esophagus, but due to an allergy. So it's usually associated with atopy. So you guys should know by now that eosinophils are more common in allergies. So that's why it's associated with atopy. So you could see it with asthma, dermatitis, or rhinitis. So what's really important about the eosinophilic esophagitis is from its name that we have prominent or a good number of eosinophils. Now, these eosinophils are not seen anywhere. They are seen only in the upper or the mid esophagus. So upper or mid esophagus eosinophilia is called eosinophilic esophagitis and is usually associated with atopy. Now, I wrote here that it's PPI resistant. Why is that important? Because in GERD, we are also going to see eosinophils. However, in GERD, the eosinophils are in the lower esophagus and they are not PPI resistant because GERD does respond to PPIs, right? And here, macroscopically, you could sometimes see multiple rings, which is shown in a classic presentation of a young male with bronchial asthma, for example, again, emphasizing the point of atopy. So here I added this classification of esophagitis from your slides. I'm not sure how important is that to your OSP. However, let's go through it. So they're basically divided into four types or four grades. Grade A is when the inflammation is less than 5 millimeters and does not cross the folds. Grade B is when the inflammation is more than 5 millimeters and also does not cross the folds. Grade C is when it starts crossing the folds and it covers a lot of the circumference, but still less than 75%. And grade D is when it covers the whole circumference of the esophagus or more than 75%. This is called the LA classification of esophagitis. Next, we have GERD. So what's really important about GERD is the three changes that you can see on histology. These are really asked to you guys, so please memorize them. So number one, we have the basal zone hyperplasia, the elongated lamina propria, eosinophil, and neutrophil infiltrations. So this is the picture for GERD. Again, please memorize the picture. It's very important. So what are some complications of GERD? Ulceration, hematemesis, melena, Barrett's esophagus is one of the most important complications of GERD as well. I just want to emphasize the point of eosinophilia. So we said in GERD, the eosinophils are most likely seen in the lower esophagus, unlike the eosinophilic esophagitis, where the eosinophils are seen in the upper or the mid esophagus. Now, talking about GERD, so you guys know that if the medical treatment and the lifestyle changes did not work for GERD, we go into surgical management. So let's go through the types of surgeries. So we have Nissen fundoplication. Please don't mind the way I'm pronouncing those. I'm not sure if they're correct. So we have Nissen fundoplication. It's a 360 wrap of the gastric fundus around the lower esophagus. So whenever you see a 360 wrap, this is Nissen fundoplication. Next, we have Toupet's fundoplication, where there is a 270-degree posterior partial wrap. Next, we have Dor, which is 180 to 200. So just memorize the picture. I'm not sure if that could come, but it's good to know. Next, we have Barrett's esophagus, which is a complication after GERD. So chronic GERD causes Barrett's esophagus. It causes red, velvety mucosal patches above the gastroesophageal junction. And of course, we have the intestinal metaplasia. So what is Barrett's esophagus? It's basically the intestinal metaplasia, goblet cells within intestinal columnar epithelium. So usually the esophagus should have squamous epithelium. However, because of the chronic stress from the gastric reflux, it's going to change into goblet cells within intestinal columnar epithelium. So this is grossly, as you can see, this is a normal esophagus. Here there is inflammation. And again, this is how it's going to look from within. Again, if Barrett's esophagus was not treated, it could go into esophageal adenocarcinoma. So esophageal adenocarcinoma is most common in the distal 1/3 of the esophagus, which makes sense because it's related to Barrett's esophagus, right? So risk factors are Barrett's esophagus and GERD, and the grading depends on the glandular differentiation. So since it's an adenocarcinoma, the grading depends on the glandular differentiation. Risk factor is Barrett's esophagus. Next, we have the squamous cell carcinoma, and this happens in the mid or the upper third of the esophagus. This picture is very famous, you guys. So mid esophagus squamous cell carcinoma, as you can see over here. The lesion is usually gray, white, plaque-like thickening, and the risk factors are Plummer-Vinson syndrome. We're going to go into this again. The grading here depends on the squamous differentiation since it's a squamous cell carcinoma. And because it's a squamous cell carcinoma, the histology is basically like the basic changes you can see in squamous cell carcinoma. We can see the keratin pearls, the NC ratio, and all those changes. Okay, so this is one of the pictures that your slides had, achalagia, bird beak appearance, most famous picture, pretty sure. Here we have the corkscrew or rosary bead esophagus. This is seen in diffuse esophageal spasm. So in diffuse esophageal spasm, the esophagus, due to the spasms, can go into this picture, which is called the corkscrew esophagus appearance. Next, we have the Chatsky's ring. So it's basically a thinning of the esophagus at a point, usually at the gastroesophageal junction or a bit above. This is called Chatsky's ring. And here we have the apple core appearance. Again, apple core is basically a sign of cancer in the esophagus or in any part of the GI tract. Here we have the esophageal web. So we have a protrusion of a thin membrane from the esophagus. So a thin mucosal membrane in the upper esophagus that causes partial obstruction. And this is very common in Plummer-Vinson syndrome. So Plummer-Vinson syndrome is a syndrome more common in females, known for a triad. So we have dysphagia due to the esophageal web, iron deficiency anemia, and glossitis. And if you guys remember, this was a risk factor for causing adenocarcinoma. Yeah, squamous cell carcinoma, for causing squamous cell carcinoma. Yes. Okay, next we have Zenker's diverticulum. Again, this is very famous and a famous picture that you might be asked on. So it's basically a false diverticulum at Killen's triangle. So what this is that the esophagus has an outpouching or an outpouch posterior to the esophagus. Food can go there and get stuck. That's why it can cause dysphagia, regurgitation, halitosis, and aspiration. So it's an important thing to note that this is a false diverticulum, and please note the pictures over here. Next, we have the mid-esophageal diverticulum. The mid-esophageal diverticulum is a true diverticulum. Why? Because it occurs due to traction from adjacent inflammation. So we have an adjacent inflammation pulling the esophagus out, causing a true diverticulum in the mid-esophagus. So we said that Zenker's diverticulum is usually at the upper esophagus. Mid here is mid-esophageal diverticulum from its name. Next, we have leiomyoma, which is a benign smooth muscle tumor. As you can see, it could be small, it could be huge, causing an actual obstruction. It could also sometimes, if very huge, obstruct structures in the mediastinal cavity. Okay, here we have the esophageal duplication cyst. It's a congenital benign, usually disorder, where we have a cyst or again a protrusion that is coming from the esophagus. If it was very huge, it can cause again obstruction. And sometimes it can have a small communication with the esophagus. So it's basically a rare congenital disorder. And that's it for the the microscopic pictures. Let's go into the manometry. So first of all, let's go through the normal esophageal manometry. As you guys can see here, we have the upper esophageal sphincter up here, and then we have the lower esophageal sphincter here, and in between we have the esophageal contraction. So it's important to note that the upper esophageal sphincter should have normal contraction, lower esophageal sphincter again have normal contraction, not like highly contracted, neither like no contraction, and the contraction of the esophagus should be continuous. So you should not see any discontinuity. It should be continuous, no gaps in between. That's how we tell that there is a normal esophageal, this is a normal esophageal manometry. So starting off with achalasia, achalasia has three types. This is type 1. Here we have complete loss of peristalsis. However, we have again the failure of relaxation of the lower esophageal sphincter. So when we see that the lower esophageal sphincter is contracting and at the same time there is no contraction in between, so no peristalsis, this is type 1 achalasia. In type 2 achalasia, the entire esophagus pressurizes together. So there is no this domino effect is not here. The whole esophagus is contracting at the same time. So this is not producing peristalsis, right? The food is not going to be able to be pushed through the esophagus. So again, we have the whole simultaneous pressure that is increasing along the whole esophagus. And again, the lower esophageal sphincter is non-relaxing. Finally, we have type 3 achalasia, where we have premature spastic distal contractions. So we have spastic premature contractions and a very high contractions in the lower esophageal sphincter, and this is the most common picture that we know, where the lower esophageal sphincter is failing to relax, and not only that, but there is hyper contraction throughout the lower esophagus. Next, we have jackhammer esophagus and hiatus hernia. So in jackhammer esophagus, there is esophageal motility disorder with excessively strong or hypercontractile peristaltic contractions, but a normal lower esophageal sphincter relaxation. So this is the difference between jackhammer esophagus and achalasia. In achalasia, we said that the LES does not relax. However, here it is relaxing normally. The hypercontractility is in the esophagus itself. طيب, that's for the jackhammer esophagus. How do I know that there is hiatal hernia? In a normal esophageal manometry, this green line over here should be one line. So it should be only one line. However, here, if you can note, we have two green lines, and that's not the normal case, right? This shows that there is a kind of abnormality. So what this is, usually there is one line because the lower esophageal sphincter and the diaphragm are at the same level. When there is hiatal hernia, the lower esophageal sphincter is above the diaphragm, so it's no more at the same level of the diaphragm. So it's going to be shown as two lines. So whenever you see two lines, just say hiatus hernia. Again, here we have two lines over here, so there is hiatal hernia. Next, we have aperistalsis and lax lower esophageal sphincter. So there is no peristalsis, and also the lower esophageal sphincter is not relaxing normally. Next, we have achalasia post-poem. So this is basically You can interpret this from a scenario. I don't think they'll just get you this picture. However, there is no peristalsis, so achalasia, and there is two lines at the bottom. So this could tell you that it is due to a hiatal hernia or like there is a low lower esophageal sphincter pressure after treatment. So again, this is a scenario thing. You would know this from the scenario itself. Next, we have ineffective esophageal motility. So this is basically when the esophagus is actually contracting. However, it's not contracting enough to produce peristalsis. So again, the bolus is not pushed properly. So you can see we have contraction here, contraction here. However, there is a gap. The contraction is not continuous. So again, it's ineffective. Next, we have fragmented peristalsis. Again, there is a good amount of contraction, better than the contraction in the ineffective esophageal motility. However, there is a gap in between, so it's called fragmented peristalsis. Next, we have the esophageal gastric junction outflow obstruction. So this is when we have an obstruction or an impaired relaxation of the lower esophageal sphincter during swallowing. However, the peristalsis is preserved. So there is normal peristalsis in the esophagus, no gap at all, it's continuous, but the lower esophageal sphincter is hypercontractile and is not relaxing normally. This is called esophageal gastric junction outflow obstruction. Distal esophageal spasm. So again, as you can see here, there is a kind of spasm in the distal esophagus, and there is hiatal hernia because the green lines, there are two green lines, even there is kind of effects underneath. So this is, again, it shows hiatal hernia. Butterfly effect is basically a manometric tracing artifact. They sometimes get this in the OSPE, so it's nothing important, it's just an artifact from the manometry. And that's it for the esophagus. Now moving on into the stomach. So let's quickly go through the types of hiatal hernia. So they're divided into four types. The first type is called the sliding hernia. This is basically when the cardia of the stomach displaces upward. So we only have the cardia displacing upward. This is called sliding hernia. The second type is when the fundus herniates beside a normally positioned gastroesophageal junction. So the gastroesophageal junction and the cardia are still in place, however, the fundus herniates. And this is called a paraesophageal hernia because it's basically beside the esophagus, right? And then in the third type, it's the mixed type of hernia where the cardia and the fundus are both herniating. And finally, when the hernia includes the whole stomach or other organs, this is the type 4 hernia. Okay, going into gastritis. So we have multiple types of gastritis. One is the autoimmune gastritis, which basically happens or most commonly happens in the fundus. So it affects the body or the fundus. It's a chronic autoimmune destruction of parietal cells in the gastric body and fundus. So it leads to achlorhydria and vitamin B12 deficiency, right? Now, what is shown in this picture, it's the immunofluorescence. Since it's autoimmune, we have increased IgG against the parietal cells, and that's what is shown in this immunofluorescence image. The labs are going to show decreased B12, increased homocysteine and MMA due to the accumulation. And this condition, again, increases the risk of carcinoid and adenocarcinoma. Next, we have the acute gastritis or the erosive gastritis. So from its name, it's a kind of erosion. They're superficial erosions with tiny hemorrhage and neutrophil infiltration above the basement membrane due to impaired defense. Now, this is caused by NSAIDs and corticosteroids most commonly. So in this picture, as you can see, we have type of hemorrhages, erosions with tiny hemorrhages. And here you can see the neutrophils infiltration above the basement membrane. Next, we have the antral gastritis. Antrum, so anything in the atrium is most commonly due to H. pylori. So chronic H. pylori antral gastritis. So what happens here is that we have hyperacidity, pro-inflammatory cytokines from this bacteria causing inflammation and gastritis. As you can see in these pictures, you can clearly see the bacteria in the folds of the stomach, and you can see here the neutrophilic aggregates. And here we have the goblet cells due to the intestinal metaplasia after chronic stress. So this is chronic H. pylori gastritis. An important complication that can happen to the chronic H. pylori is the mild lymphoma. Next, we have the chronic atrophic gastritis. So this is basically when the stomach reaches the point of atrophy. So we have atrophy, mucosal gland atrophy, epithelial metaplasia, and there is no erosions over here. So what this can cause later on is basically dysplasia and carcinoma. So as you can see, this is the normal stomach, and here we have the atrophy of the glands and of the normal epithelium of the stomach. And here as well, you can tell that the stomach is shrunk and atrophied. Next, we have the acute peptic stress ulcers. So from their name, they're stress ulcers. They're multiple small, sharply demarcated ulcers that are often shown in critically ill patients. So these ulcers usually happen from stress. This stress could be due to burns or trauma, and this is when they're called Curling's ulcers. So this is very important. Curling's ulcers are from burns or trauma. Cushing's ulcers are from brain injury due to the increased vagal tone. And that's how they look. They're very small and black in color. Next, we have peptic ulcer disease, which is basically an ulcer that is extending to the submucosa. The complications are pain, bleeding most commonly, and sometimes perforation in severe cases. So as you can tell, the ulcer is very deep in the stomach due to chronic stress. Next, let's move on to the polyps. So first of all, we have the gastric hyperplastic or inflammatory polyps. Those are the most common gastric polyps. On histology, you can see that we have dilated foveolar epithelium, which is basically the normal epithelium of the stomach. They are dilated and inflamed. So the pathogenesis of these, they basically arise from chronic mucosal damage due to H. pylori. So when we have H. pylori or chronic H. pylori gastritis, the patient could develop gastric hyperplastic polyps due to the chronic damage. Next, you have the fundic type polyps, and from its name, those happen in the fundus of the stomach. This is due to PPIUs. So what causes fundic type polyps is the PPIUs, the increased gastrin secretion, and glandular hyperplasia. An important thing to note is that they are related to familial adenomatous polyposis. And if that was the case, then they have a higher risk of being malignant. So again, this is the fundic type polyposis. Note the picture, please. Next, let's move on to the gastric adenoma. Gastric adenoma are basically, I don't want to say benign because they can progress into adenocarcinoma as they increase with size, but when they are still in this shape and in this size and mucin producing, then they are benign. So here, as you can see, this is an adenomatous polyp, and this is an intramucosal carcinoma. So it's an intramucosal carcinoma in the upper half invading the adenomatous polyp over here. And again, this is the gastric adenomatous polyp. You can tell from the color that it's mucin producing. That's why it's very clean or like very, the color is the same through all the picture. It mostly happens in the antrum. Risk of progression to adenocarcinoma again increases with size. And this is gastric adenocarcinoma. So it's important to note the signet ring sign. So you guys have two types of gastric adenocarcinoma. We have the diffuse type and the intestinal type. So how about we go through the table first? So I made this table just for you guys to differentiate between the two. The diffuse type, from its name, it's diffuse. It can happen at any part of the stomach. The intestinal type, it usually occurs on the antrum or on the lesser curvature. The diffuse type on histology has signet ring cells, which is very important. The intestinal type is gland forming. That's why it's called intestinal. On the gross appearance, diffuse type has lenitus plastica or thickening on the rigid stomach wall. And in intestinal type, we have the ulcerated mass or polyp. The risk factors for the diffuse type is the DH1, CDH1 mutation. However, in intestinal type, it is the H. pylori infection. Okay, so now going back into the gastric adenocarcinoma, the diffuse type, again, here we have the signet ring appearance. So the nucleus is at the periphery of the cell, giving this appearance. As you can see here, we have lenitus plastica, which is the thickening of the wall of the stomach, and it's very prominent, right? And again, the mutation is CDH1 mutation. Next is the gastric adenocarcinoma intestinal type. So it's due to chronic gastritis, most commonly due to H. pylori infection. So as you can see, the metaplasia is intestinal. We have intestinal metaplasia, and it can cause ulcers, as you can see over here. Okay, these are very important pictures in the GIT block. We have Sister Mary Joseph's note. So these are signs of metastasis of any GI cancer. We have Sister Mary Joseph's note. I remember there was a story behind this. If you guys are interested, you can go back and look at it. So here we have Virchow's node, where the metastasis goes to the left supraclavicular lymph nodes. Next, we have Blummer's shelf, which is basically the pouch of Douglas, and Trichenberg's tumor, which is when the metastasis goes into the ovaries. Now we have the gastric carcinoid tumor, which is known for its appearance. So we have the monotonous cells with salt and pepper appearance. So they're monotonous because they all look the same, salt and pepper. We have white and black circles all around. And here we have the nesting pattern. So it's very important to note that these arise from the ECL cells or the neuroendocrine cells, and that their effect is not seen due to the first pass effect. So what this means is that although the gastric carcinoid tumors, they produce hormones, these hormones do not cause any effect because there is first pass effect by the liver. But when do symptoms appear? Symptoms appear if liver metastasis occurred because there is no more first pass effect, right? This is mostly associated with PPI, autoimmune gastritis, or the Zollinger-Ellison syndrome. Next we have is just or gastrointestinal stromal tumor. This is one of the most commonly asked tumors in your exam and forever. So on histology, you can see again monotonous spindle-shaped cells. So as you can see here, they're spindle-shaped cells, and there is central umbilication and ulceration on the gross pictures. So here we have the central umbilication and ulceration. They are made up of the interstitial cells of Cajal with c-KIT mutation. I did not put any treatments in this session. However, this is very important. They are treated by tyrosine kinase inhibitors, which is imatinib. So again, just tumor, spindle-shaped cells, central umbilication and ulceration. They have c-KIT mutation, and the treatment is tyrosine kinase inhibitors, imatinib. Again, we have a lipoma, which is the same as a leiomyoma تقريبا يعني. However, lipoma is most commonly it occurs from fat, not smooth muscle cells. Here they are identified by endoscopy and a cushion sign, where they are very smooth and compressible. And that's it for the upper GI tract. Now we can move into the lower GI tract. So these are some of the important skin manifestations in inflammatory bowel disease. First of all, we have the erythema nodosum, which are basically types of hyperpigmentation or bruises on the front area of the legs. This is called erythema nodosum, again, a sign of inflammatory bowel disease. And next we have the pyoderma gangrenosum, which is a kind of ulcer, you can say, again, on the front part of the leg or the hand. It can occur on both. So pyoderma gangrenosum, again, a skin manifestation of inflammatory bowel disease. Okay, now a lot of pictures. So we have here the creeping fat appearance, non-caseating granuloma, strictures, linear ulcers, again, ulceration, and the cobblestone appearance. As you can see here, we have the cobblestone appearance. So what are all these signs of? Crohn's disease. Crohn's disease is known for the transmural inflammation and skip lesions affecting any part of the GI tract. However, it's most commonly seen in the terminal ileum, ileocecal valve, and in the cecum. So again, grossly, they have aphthous ulcers, cobblestone appearance, strictures, creeping fat, and fistulas. Histologically, there are crypt abscesses, lymphoid hyperplasia, and most importantly, the non-caseating granulomas. Guys, please memorize a couple from the gross and the histological appearances of Crohn's disease. So this is the picture that was provided in your slides for Crohn's disease, and this just shows the disease progression. This is on MRI. There are some signs that can also show Crohn's disease, but they're not diagnostic. Here we have Combs sign, as you can see. Here we have the anterior vesical fistula, which is basically a fistula communicating the intestines with the bladder, and again, the target sign. not very non-specific. It can be seen in a lot of diseases. Again, here we have the stricturing and the penetration or the fistula formation. Okay, here we have two other pictures. Here we have a sign of loss of hostra or lead pipe appearance, and here we have the pseudopolyp. So what are these signs of? Ulcerative colitis. In ulcerative colitis, it's basically an inflammatory bowel disease that involves mainly the rectum and then extends proximally. So in ulcerative colitis, the rectum should be involved, and it's continuous, unlike Crohn's disease. On histology, we have cryptitis, crypt abscesses, and inflammatory infiltrates limited to the mucosa and submucosa. What's very important about this disease is that it increases the risk of primary sclerosing cholangitis, toxic megacolon, colorectal adenocarcinoma, and smoking is protective against it. It's also associated with HLA-DR103 mutation. Now, moving on to the polyps. I hate this part of the lecture. However, inshallah, it's not going to be too hard. So first of all, let's differentiate between the sessile and the pedunculated. Sessile intestinal polyp basically do not have a peduncle. Or stalk, sorry. So there's no stalk. They're just occurring on the wall of the intestines. However, here, as you can see, there is a prominent stalk. So starting off with Peutz-Jeghers syndrome, I really hope I'm pronouncing that right. So it's a rare autosomal dominant disorder characterized by hamartomatous polyps throughout the GI tract. So again, this is a kind of multiple polyps that occur throughout the whole tract, and they are also linked with mucocutaneous hyperpigmentation, so dark blue-brown macules on lips, buccal mucosa, and fingers. So whenever you hear about polyps and hyperpigmentation, think about Peutz-Jeghers syndrome. We have LKB1 mutation, multiple hamartomatous, as we said, which is benign overgrowth of the normal tissue of the intestines. It increases the risk of GI and non-GI cancers. This picture comes a lot in OSPE, guys, so please make sure that you know it very well. So again, this picture, Peutz-Jeghers syndrome, hamartomatous polyps, as well as mucocutaneous hyperpigmentations. Next, we have the juvenile polyps, which are the most common hamartomatous polyps in children of less than 10 years old, and they can sometimes cause rectal bleeding. Those are sporadic. They can be sporadic, or they can come with other syndrome, including the juvenile polyposis syndrome. Again, the number of polyps, the more number of polyps, the higher risk of GI or pancreatic adenocarcinoma. On histology, we have cystic spaces with mucin or inflammatory debris. So memorize this picture. I don't know how to relate that, but it kind of looks like a baby. This is the head and these are the hands. So think of juvenile polyps. Next, we have the hyperplastic polyps, which are common benign polyps in adults. They're basically hyperplasia of the glands. So you can see that there are goblet cells, intestinal epithelium, which is the columnar epithelium. Here we have the adenomas. So we have two types of adenomas, the tubular adenoma and the villus adenoma. The villus adenoma is columnar or like long, and the tubular adenoma, because it's a cross section, you can see that they look like cross sections of tubes. Next, we have the sessile serrated adenoma. This is most common in the right colon and is pre-malignant. So since it's sessile, there is no peduncle, so you can see that it extends from the basement membrane. So whenever you see a polyp that is extending على طول from the basement membrane, as you can see here, we have يعني subcutaneous fat, right? So this is the basement membrane, وعلى طول there is the adenoma, but this is sessile serrated adenoma because there is no stalk. It's associated with hypermethylation and BRAF mutation. Next, we have the familial adenomatous polyposis, which is basically a familial disease with APC gene mutation. So APC gene mutation is in familial adenomatous polyposis. Two important subtypes are the Gardner syndrome and the Turcot syndrome. So whenever you have polyposis, or a lot of polyps in the intestines, along with osteomas, epidermal cysts, and dental issues, think Gardner syndrome. Whenever you have polyposis and CNS tumors, think Turcot syndrome. I think there were two more mentioned in your slides, but these are the most important: Gardner syndrome, osteomas, Turcot syndrome, and CNS tumors. Next, we have the colorectal adenocarcinoma. So an important thing to note over here is that we have right-sided colorectal adenocarcinomas and left-sided colorectal adenocarcinomas. The difference is that in the right side tumors, they cause anemia and fatigue. And why is that? And why don't they cause obstruction like in the left-sided tumors? Right-sided tumors, or like the right side of the colon, is usually uh, like wider than the left side. So because it's wider, it's less prone to cause obstruction. So we won't have any signs before the bleeding happens. So we just have bleeding and we're going to have occult blood in the stools, anemia, and fatigue. And the left side tumors, because they are kind of narrower, for the obstruction is going to happen before the anemia and fatigue occurs. So this kind of cancer worsens with the depth of invasion, lymph node metastasis, mucinous or signet ring, liver, lung, bone are common metastasis. So please note the pictures again, colorectal adenocarcinoma. Next, we have the mucocele, which is just a dilated appendix that is filled by mucin. So note the picture, please. It comes commonly in OSPE. Next, I'm just going to talk about some signs of bowel obstruction. So as you can see over here, we have loss of hostra and a dilated bowel. Here we have air fluid level, again, distended bowel, air fluid levels, and here we have a very dilated bowel. Next, we have signs of perforation. So what are some signs of perforation? There is air under the diaphragm. Whenever you see air under the diaphragm, think perforation. And there is this sign called Wriggler's sign. So Wriggler's sign is basically when there is free intra-abdominal air. Okay, so when there is free intra-abdominal air, as you can see over here, for example, this is called Wriggler's sign. Next, an important condition is pneumatosis intestinalis. This is very important. So it's basically when you see air between, like within the wall of the intestines. So this is the wall of the intestines. You can see that there is a gap between the wall of the intestines, like air between the walls. And why is that? It's because of the widening of the intestines, because it's very huge. There is a kind of perforation that occurred that to the point that the air has reached to the walls between the intestinal walls. Next, we have thumb printing. Again, it's a radiological sign that could indicate bowel wall ischemia. As you can see here, we have thumb printing. It's not only limited to bowel wall ischemia, any kind of obstruction can cause thumb printing signs. Next, we have the volvulus. Again, this is very important. We have two types of volvulus. We have the sigmoid volvulus and the cecal volvulus. The sigmoid volvulus occurs in a coffee bean sign or an inverted U sign, and it extends to the right upper quadrant because that's where the sigmoid is, right? Next, we have the cecal volvulus, which looks like a kidney. It's a kidney-shaped sign or a C-shaped sign, and the convexity extends to the left upper quadrant. Okay, so you had this picture in one of your clinical lectures. I don't know if it's important, however, let's go through it. So this is the colon transit study. It's basically a study where you give the patient rings to swallow, I think 20 or 25 rings, and then you see how many are left in his colon after a specific amount of time. So if 5 or fewer markers remain, the patient has grossly normal colonic transit time. If most of the rings are scattered about the colon, the patient might have hypomotility or colonic inertia. If the patient has most of the rings gathered in the rectosigmoid region, the patient might have a functional outlet obstruction. You can see this is the normal liver. This is how it's supposed to look like. However, in a cirrhotic liver, you can see that there is some fibrosis in the periphery, and in the middle we have the regenerative nodules. So this cirrhosis happens due to a shift from a type 4 to a type 1 or 3 collagen, causing the thickened or the fibrotic liver. One thing to note is that a liver that is cirrhotic is basically smaller in size and not larger. So if they mentioned causes of hepatomegaly, never mention cirrhosis because it basically causes the liver to shrink. So what are some causes of liver fibrosis? So we have three main causes. We have hepatitis B virus, C virus, and the autoimmune hepatitis. So starting with the B virus, it basically is seen as a ground glass appearance, as you can see over here. So this is the ground glass appearance, and here we have the surface antigen accumulation in the cytoplasm. sorry, over here. So here we have the surface antigen accumulation in the cytoplasm and the ground glass appearance. Here on the right, we have the Councilman bodies due to the T cell induced apoptosis. So again, this causes a risk of cirrhosis, hepatocellular carcinoma. However, it does not cause steatosis. Steatosis is mainly seen in the hepatitis C virus. So hepatitis C virus causes chronic hepatitis. Transmission is due to IV drug use, and complication again, they include cirrhosis, hepatocellular carcinoma, and steatosis. Next, we have the autoimmune hepatitis, and the most important keyword over here is the interface hepatitis. So we have interface hepatitis causing autoimmune or seen in autoimmune hepatitis, and this is more commonly seen in females as it's autoimmune and it's associated with HLA-B8 or HLA-DRW3. For treatment, we use steroids as the first line. This is a quick comparison. So for the liver biopsy and HBV, we have the ground glass hepatocytes, moderate inflammation. In the HCV, we have the lymphoid aggregates, mild fibrosis. In the autoimmune hepatitis, we have the interface hepatitis, and the plasma cells are usually prominent. Now, these are common, very important pictures. Yani in the GI block, we have the Mallory bodies over here, which are basically seen in whenever there is hepatocellular injury. And here, as you can see, there is polymorphonuclear surrounding necrotic hepatocytes. So here we have the hepatocytes that are basically necrotic. Okay, so here we have hepatomegaly. Hepatomegaly is usually seen in alcoholic liver disease. So as you can see, the liver is enlarged and there is a kind of steatosis, right? So it can progress into steatosis, alcoholic liver disease, and then later on it can cause cirrhosis. However, what is seen in this picture is the hepatomegaly. Most commonly in alcoholic liver disease, the liver enzymes are going to be, the ratio is AST more than ALT with a 2 times ratio. Moving on to the pancreas. So here we have an ectopic pancreas. So from its name, you could tell that there is normal pancreatic acini and ducts in the submucosa, however, in a different position. So it could be in the stomach, duodenum, or jejunum. This is how the histology looks like. You can see the acini and the ducts of the pancreas that is seen in the stomach, like it's seen in this picture. So these are some signs of acute pancreatitis. So we have the Cullen sign, and that's very important to note. Cullen sign, which is a huge bruise or hemorrhage in the mid-abdomen, or we have Gray Turner sign. Gray Turner sign, where the hemorrhage or the bruise again is at one side of the abdomen. So this is acute pancreatitis on a CT scan. You could tell that there is peripancreatic necrosis over here and that the pancreas is inflamed. On histology here, you can see the parenchymal and fat necrosis of the pancreas due to the inflammation. Type, how do we diagnose pancreatitis? There is an important criteria to diagnose pancreatitis, which is 2 of 3 criteria. So those are epigastric pain radiating to the back, which is the classic presentation of pancreatitis. Next, amylase and lipase 3 times the upper normal limit or level, and of course imaging. So the classic CT gold standard imaging, and we can use also Ranson criteria for predicting the severity. So for severity, you go for Ranson. However, for diagnosis, you use the 2 out of 3 criterion. So what are some causes of acute pancreatitis? We have the eye gets smashed pneumonic. It could be idiopathic gallstones, which is most common in adults, ethanol or alcohol, trauma, steroids, mumps, autoimmune, scorpion sting, hyperlipidemia, endoscopic or ARCP, and finally we have the drugs. So this is one of the complications of acute pancreatitis, which takes 4 to 6 weeks to form after acute pancreatitis, and that is the pancreatic pseudocyst. So this is a very commonly asked picture. So this is the pancreatic pseudocyst, as you can see on a CT scan, and this is how it looks grossly. So if this pseudocyst is near the ampulla of Vater, it can cause obstructive jaundice. Of course, this is made of, the epithelium is not true epithelium. Next, we have chronic pancreatitis that happens after recurrent acute pancreatitis. So it could be caused by alcohol in adults or cystic fibrosis in children. What's really important to note is the hereditary types. We have the autosomal dominant, PRSS1, and this is asked. And we have the SPINK1. So SPINK1, the autosomal recessive, and the PRSS1 is autosomal dominant. So again, here, as you can see, that there is a kind of inflammation in the pancreas. Just memorize the pictures. So on imaging, chronic pancreatitis can show calcification. So whenever you see calcifications, for this means that the pancreas has been going through an inflammation for a long time. And on the ERCP, you can see that there is chain of lakes appearance. Complications, again, it can cause chronic epigastric pain, splenic pain, thrombosis is very important, and pancreatic insufficiency. Next, moving on to the tumors. We have first the serous cystadenoma, which is a benign tumor in the pancreas. It involves the older females and occur in the body or the tail. So they're basically small cysts that are lined by cuboidal epithelium and filled with clear fluid. So cuboidal epithelium filled with clear fluid. This is serous cystoadenoma seen in the pancreas, and it's basically associated with the VHL mutation. Next, we have the mucinous cystic neoplasm. This produces mucin. So unlike the other one, which is serous, this is mucin. It produces mucin, and this has columnar mucinous epithelium with ovarian-type stroma. So this is pre-malignant. The mutations could be KRAS, TP53. As you can see, this is the gross picture, and this is the histopathological picture. Note the columnar epithelium. Next, we have the pancreatic adenocarcinoma, and on histology, you can see how we have the desmoplastic reaction, which is basically when there is fibrotic tissue around the inflammation. We have kind of fibrosis around the inflammation. So pancreatic adenocarcinoma is a painless obstructive jaundice. It causes painless obstructive jaundice when in the head of the pancreas because it can block the biliary tract. Important tumor markers are the CA19 and the CEA. However, they're not commonly asked. It can show this sign, Courvoisier's sign, which is a palpable gallbladder and painless jaundice. Metastasis could be to the Virchow's node or to the Blummer shelf. Next, we have cavernous hemangioma. This is the most common benign liver tumor. It involves vascular channels subcapsular and it can mimic metastasis. Percutaneous biopsy risks severe bleeding. So since it's hemangioma, so we do not tend to do a biopsy. It's a benign tumor of the liver. Next, we have the focal nodular hyperplasia, and this is a very important picture. So this is the focal nodular hyperplasia. Focal nodular hyperplasia, it involves a central stellate scar. So whenever you hear central stellate scar and estrogen, which is more common in females, think focal nodular hyperplasia. In histology, we have the fibrous bands with ducts and vessels. Next, we have the hepatic adenoma, which is a benign tumor of the liver again. It is related to oral contraceptives. And a subtype is the beta-catenin, which is a high-risk tumor. This is one of the pictures that were in your clinical slides. So it's a liver dysplastic nodule. I don't think you'll get that. Next, we have the hepatocellular carcinoma, which is linked to HBV, HCV, alcohol, and some mutations. As you can see over here, you can also see the Mallory bodies. However, this is not magnified enough. So since it's hepatocellular carcinoma, the AFP is going to be very high, which is a tumor marker of the hepatocellular carcinoma. We're going to go through the tumor markers at the very end of the session, inshallah. Here we have the gallbladder carcinoma, most common biliary malignancy. It's strongly linked to gallstones and chronic cholecystitis. And again, this sign is positive, where we have a palpable and non-tender gallbladder with jaundice. Next, we have cholangiocarcinoma, which is aggressive bile duct adenocarcinoma. So it's adenocarcinoma of the bile duct. Risk factors is the PSC, primary sclerosing cholangitis, again, which was a risk factor for, which was a complication, of ulcerative colitis. Again, we have adenocarcinoma, and you can see again the desmoplastic reaction around the inflammation. And inside we have mucin, intracellular mucins. So this is cholangiocarcinoma. You can see that the lesion is beside the biliary tract. Next, we have the pseudomyxoma peritoni. So what this is, it's basically intraperitoneal spread of mucin-producing tumors. So you have tumors that are mucin-producing and they just extend or spread into the intraperitoneum. They usually occur from the appendix or the ovary, and they're mucin-filled, causes a mucin-filled abdomen. So as you can see here, a lot of mucin, and this is how it looks grossly. Pseudomyxoma peritoni. Okay, so now I think we're going to talk about Mersey syndrome. So let's go through the normal tract. So this is the gallbladder. As you can see, the first duct is the cystic duct, and then we have the common hepatic duct and the common bile duct. So the cystic duct joins the hepatic duct and make the common bile duct. After that, it joins with the pancreatic duct over here, and this is the ampulla of Vater. So what happens in Mersey syndrome is that we have a gallstone that is stuck in the gallbladder neck or in the cystic duct, as you can see over here, the cystic duct. It compresses the common hepatic duct as well, so it increases intraluminal pressure, causing obstructive jaundice and cholangitis. So for diagnosis, we go for ERCP. So a question once came as Mersey syndrome, what duct will be obstructed, or the stone will be in what duct, and we had to choose this part. Okay, so here, as you can see, this is a gallstone ileus. So here we have pneumobilia. So what pneumobilia is, it's basically air in the gallbladder or in the biliary tract, as you can see over here. And here you can see the stone at the ileocecal valve. So these are pictures of gallstone ileus, where there is a stone that is causing an obstruction. So we have chronic reactive cholecystitis causing a fistula to the duodenum and a stone over there obstructing the flow. Here we have chronic cholecystitis or chronic inflammation of the gallbladder, and what this can cause is the porcelain gallbladder, which is also occurring over here. As you can see, the gallbladder is calcified, so this shows a porcelain gallbladder or a chronic case of cholecystitis. Next, we have the secondary biliary cirrhosis. This happens to prolonged extrahepatic biliary obstruction. So it's secondary extrahepatic obstruction causing cholestasis, fibrosis, and cirrhosis. So again, these are pictures of secondary biliary cirrhosis. Next, we have the primary biliary cholangitis, PBC. So this most commonly comes in a scenario of a female who is experiencing fatigue and ruritis, right upper quadrant pain. So ruritis, right upper quadrant pain, increased ALP is very important. These are all seen in primary biliary cholangitis, and it's linked to autoimmune disease. Unlike the primary sclerosing cholangitis, which is known for fibrosis and strictures of the intra and extrahepatic bile ducts, this one is most commonly associated with ulcerative colitis. Now, an important thing about this is that in the histology, you can see the periductal or onion skin fibrosis. So whenever you see onion skin fibrosis, as you can see over here, for this is primary sclerosing cholangitis, and this is very important to note. Next, we have hemochromatosis, which is basically increased iron absorption. So we have iron residuals or iron being stored in multiple organs, as you can see over here in these pictures. The iron is prominent. This is due to a C2A2Y mutation, and it's an autosomal recessive disease. Next, we have Wilson's disease, which is again an autosomal recessive mutation. It causes decreased copper excretion into bile, so copper accumulation. On labs, you're going to see increased urine copper, increased hepatic copper, and decreased seroplasmin. For treatment, we give penicillamine and zinc, which are basically chelating agents. And this is one of the signs of Wilson's disease, Kayser-Fleischer rings. So they're basically deposition of copper in the eye, causing these rings, Kayser-Fleischer rings. Okay, now for our next checkpoint, we're going to go through microbiology, starting off with E. coli. E. coli is a gram-negative bacilli, oxidase negative, indole positive, motile, member of Enterobacteria, of course, and it is a lactose fermenter on McConkey agar. So this is a McConkey agar, as you can see. It's a yellow-colored agar. Because E. coli is a lactose fermenter, it's going to change the color of the agar into pink. So E. coli is a lactose fermenter. Here you can see a lactose negative agent, and that would be Shigella and Salmonella. We're going to go through that in a bit. E. coli can also ferment sorbitol. So, or all types of E. coli ferment sorbitol. However, only one, which is the enterohemorrhagic type, they do not ferment sorbitol, and we're going to go through that. Now, we're going to talk about four types, I think four or five types of E. coli. The doctor explained them. So first of all, we have the enterotoxigenic E. coli. Of course, we're talking about diarrhea. So all these agents that we're going to explain are agents that can cause diarrhea in susceptible patients. Starting off with the enterotoxigenic E. coli. So this E. coli causes watery diarrhea. What's important to note is that it has heat labile toxin and heat stable toxin. These pictures are very important to you guys. They can get you a scenario or like a scenario and ask you which bacteria or what is the or they can get you just the picture and you choose the type of bacteria that is responsible for this pathogenesis. So see, whenever you see heat labile, stable toxin, increasing cyclic AMP and cyclic GMP, think about enterotoxigenic E. coli. Next, we have the enteropathogenic E. coli. So what they do is that they do the attaching and effacing histopathology. So they attach to the microvilli and they efface them. So they efface them and the microvilli cannot do its normal absorption function. So unabsorbed nutrients and water expelled as diarrhea. Next, we have the enterohemorrhagic coli, E. coli 0157H7. This is very important. This E. coli is the one that, these are the ones that are non-sorbitol fermenters, as we mentioned earlier. Now, the pathogenesis of this is related to a Shiga toxin. So as you can see here, we have the Shiga toxin that is going to cause the pathogenesis. Remember this picture for enterohemorrhagic E. coli. These kind of bacteria, they cause bloody diarrhea and might develop into hemolytic uremic syndrome if antibiotics were used. That's why we avoid using antibiotics. Next, we have the enteroaggregative E. coli. This is where the bacteria enter the intestinal lumen. They aggregate and then they are going to block the villi again, blocking the absorption. They're going to produce their toxins and block the absorption of the nutrients, again causing watery diarrhea. Finally, we have the enteroinvasive E. coli. Again, those use the Shigella toxin, Shiga toxin, and they are very similar to the Shigella. They induce apoptosis in macrophages, so the bacteria are released and can invade the epithelial cells from the basolateral side. So they enter, they're going to invade the enterocyte, and then they're going to invade the other enterocytes from both sides. Next, we have the Campylobacter. So Campylobacter is a gram-negative, as you can see, it's pink, gram-negative, curved bacilli, oxidose positive, non-spore-forming, microaerophilic, motile, bipolar flagella, non-fermenter. It cannot grow under strictly aerobic condition. So for this Campylobacter, we can use two types of agars. We have the Campylobacter charcoal differential agar and the Campi agar. So it basically comes from undercooked chicken, most likely. However, it can come from other types of food. It causes inflammatory diarrhea, either bloody or watery. So how it works is that by this picture, as you can see, we have Campylobacter by chemotaxis and motility. They come, they attach, they invade, and they entrap. They cause loss of absorptive microvilli. So what's important over here is that they cause watery diarrhea and sometimes dysentery, and they are also linked to Guillain-Barré syndrome. Next, we have V. cholera, which is a gram-negative curved bacilli. This picture is very important to you guys, V. cholera, and this bacteria is known for causing the rice water stools. This bacteria grows on the thiosulfate citrate bile salt sucrose agar. So this is the thiosulfate citrate bile salt sucrose agar. So this is its pathogenesis. So it's made up of two subunits. We have the A and B. I don't want you to go through details. Just get familiar with the picture. They go in and they get attached to the endoplasmic reticulum and then they work on the adenylate cyclase. Next, we have the Shigella. As we said, Shigella is non-lactose fermenter. So on a McConkey agar, it's not going to turn pink. It's going to stay yellow. So what we do is that we use the Shigat Salmonella agar, and it's not going to produce any black dots. So it's a gram-negative, non-motile, non-spore-forming bacilli, oxidase negative, and lactose non-fermenter. There is no hydrogen sulfate production, so no black dots. And because of the Shiga toxin, it can produce hemolytic uremic syndrome. This is the picture that was put in your slides for the type of diarrhea. Of course, it causes dysentery. And you can use this agar as well, XLD agar. This is the pathogenesis. Again, the Shigella toxin, it goes in and it causes, it invades the cell, the whole cell, and then it phagosome lysis and macrophage apoptosis, and it causes the bloody diarrhea or the dysentery. Next, you have the salmonella. Salmonella has hydrogen sulfate, produces hydrogen sulfate, causing black dots of salmonella on the Salmonella shigella agar. So it's motile, lactose non-fermenter again, and survives in macrophages. Now, these are clinical signs of the typhoid fever that can be caused by the Salmonella and the Shigella. So here we have the rose spots, as you can see, and the pea soup stool. So these are clinical presentations of typhoid fever, fever with relative bradycardia, and constipation preceding the diarrhea. So before we have the pea soup stool, we have constipation. So this is the difference. This is E. coli on the McConkey agar. Salmonella produces the black dots, and Shigella does not produce anything of that. Next, we have the C. difficile. Very important, C. difficile is gram-positive anaerobe spore forming triggered by antibiotics. So it grows on the cycloserine, cefoxitin, fructose agar, or the cycloserine agar. So as you can see over here, those are very strong antibiotics that they kill any other bacteria other than C. diff. That's why they can grow on those agars and nothing else can grow over there. This is how they look. So they're spore forming. That's very important, C. diff, and they can cause pseudomembranous if it's linked to antibiotic use. Okay, so they're related to toxic megacolon, as you can see, and the diarrhea would be mucoid and foul smelling. Clinical presentation includes fever, abdominal pain, diarrhea is usually non-bloody with a distinct odor. So this is how it works. Again, we have two types of toxins. Toxin A, which causes an enterotoxin causing diarrhea. B, cytotoxin, pseudomembranes, and it could be detected on an ELISA testing. So this is the picture that was provided for you guys. So toxin A and B go in and so on. Just know the picture, be familiar with the picture in case it comes in your OSPE. Next, we have Clostridium botulinum. So this causes a neuroparalytic syndrome resulting from the action of a neurotoxin. So what it happens is that it produces the toxin, blocks the secretion of the acetylcholine over here. So it inhibits the contraction, again causing neuroparalytic syndrome. It's associated with the consumption of home canned food and homemade honey. So whenever you see a picture of canned food, a patient going through paralysis or weakness of muscles, think about Clostridium botulinum. And this is the pathogenesis. Next, we have Staph aureus. So Staph aureus, again, is a gram-positive cocci, of course. It comes from creamy dishes, eggs, and salads. The enterotoxin is that it produces is superantigen. So whenever you hear superantigen, think about Staph aureus. Symptoms start within 1 to 6 hours after ingestion. Now, what's important about this superantigen is that it sometimes can cause a massive cytokine release, causing fever, rash, and desquamation, as you can see in this picture, which is known as the toxic shock syndrome. Next, we have the Bacillus cereus. So it's a motile gram-positive aerobic bacilli. It's catalase positive and spore forming. This is the picture that was provided in your slides. So we have two types. We have the emetic syndrome that is mediated by highly stable toxin and the diarrheal illness that is mediated by enterotoxin, which is heat and pH labile. So Bacillus cereus over here, and it comes from rice. Next, we have, let's go through the parasites, done with the bacteria. So we have Giardia lamblia. It comes from contaminated water, known for doing foul-smelling, non-inflammatory watery diarrhea and steatorrhea. So they disrupt the fresh border and cause villus atrophy. So this is the trophozoite, and these are the cysts of Giardia lamblia. As you can see, ingestion of dormant cysts, either from contaminated water, and then they can cause duplication of trophozoites and the infection. Entamoeba histolytica, again, contaminated food or water, invasive dysentery. So unlike Giardia, which causes only watery diarrhea, Entamoeba histolytica causes invasive dysentery, so bloody diarrhea and abdominal pain, and it can sometimes cause extra intestinal amoebiasis that is caused by the migrating trophozoite. So here we have a trophozoite, and here we have the cyst of the entamoeba histolytica. As you can see, the trophozoites, they have more than 4 nuclei. So these are the extraintestinal amoebiasis. It can go into the liver, causing amoebic liver abscess, chocolate appearance, or it can go into the intestines, causing amoebic colitis. Now for Cryptosporidium, this is an opportunistic enteric parasite, so it's most common in immunocompromised patients. It grows on a modified acid-fast stain. So whenever you see in this block, I think this is the only organism that grows on acid-fast stain. So if you see this picture, think Cryptosporidium. Okay, transmission is fecal oral. Again, it's seen in opportunistic enteric parasite, and it causes watery diarrhea. Next, we have the Strongyloids stercoralis. So this is basically a worm that comes from the soil. So it goes from the soil to the skin and then to the lungs. If swallowed, it can go into the small intestine and cause an autoinfection, of course. So autoinfection, the larvae re-enter the circulation, causing hyperinfection in immunocompromised patients. The risk factor is corticosteroid therapy. So as you can see, this is the larva beneath the skin, can be seen, and this is the filariform larva of the worm, and this is its shape on a slide. This is its pathogenesis. So what's important to note here is the soil. So it transforms to filariform larva, and then the larva enters the host through the skin. It migrates to the lungs, grows in the alveoli, and it can cause autoinfection from the filariform larva that is circulating in the blood. Moving on to viruses, so you guys only have 3 types of viruses. We have the rotavirus, which is a double-stranded, non-enveloped, wheel-shaped virus. As you can see over here, it's wheel-shaped. This is the leading cause of severe gastroenteritis in children less than 5 years of age. Common complications are dehydration and intussusception. So please keep in mind intussusception for rotavirus and this picture, which shows a wheel-shaped virus. So this is the pathogenesis. We have villus atrophy and malabsorptive diarrhea, again causing watery diarrhea. Next, we have norovirus. This is a single-stranded RNA virus that also causes watery diarrhea. This is how it looks in the picture. Complications, of course, dehydration. Dehydration was very much emphasized in your lecture. Please note that norovirus causes dehydration. So to diagnose the patient with norovirus, we go through the Kaplan criteria, vomiting in more than half of the symptomatic cases. It goes through an incubation period of 24 to 48 hours or the illness of 12 to 60 hours, and that there is no bacterial pathogen isolated on stool. If all the Kaplan criteria are positive, there is a high probability of a norovirus outbreak. Finally, we have the enteric adenovirus. So it's basically a non-enveloped particles composed of a nucleocapsid and double-stranded DNA. It infects mucoepithelial cells in the respiratory tract. What's important here is the histology. So the histologic hallmark of adenovirus infection is a dense central intranuclear inclusion. As you can see over here, it's an intranuclear inclusion that consists of viral DNA and protein. So whenever you see this picture, please think enteric adenovirus. And that's it for the microbiology. Let's move on to the radiology. So the radiology part is very easy actually. I just want you guys to revise these before your exam. Like I used to revise them literally 10 minutes before the exam because the exact pictures come and they're very easy, inshallah. So this is a classic picture of a coin that is stuck either in the trachea or the esophagus. So it's just telling you that how to differentiate between both. If it was stuck in the trachea, in this view, it's going to look diagonal. If it's stuck in the esophagus, because the esophagus is, wider, it's going to be in the horizontal shape. So just memorize the way it looks. Okay. So here we have, this is a peptic stricture due to reflux esophagitis. So this is a benign inflammatory stricture. So reflux esophagitis leads to narrowing of the distal or mid-esophagus over time. So you can see that we have multiple strictures and these are inflammatory, not malignant. Next, we have esophageal web. If you guys remember, we talked about that. It's basically when there is a thin membrane that is protruding from the esophagus, and it's common in Plummer-Vinson syndrome. If you guys remember, we mentioned that there is triad, iron deficiency anemia, glossitis, esophageal web, or the dysphagia that we mentioned. The web is basically a shelf-like projection that causes a short segment, narrowing or obstruction in the esophagus, causing the dysphagia. Here we have infantile hypertrophic pyloric stenosis. This is very important. The exact same picture comes every time. So memorize it. Infantile hypertrophic pyloric stenosis. This is caused by delayed gastric emptying. So it causes gastric outlet obstruction, and it's most commonly seen in newborns. So in newborn that is having projectile non-bilious vomiting, clinical diagnosis can be seen as an olive or on physical exam. Next, we have Crohn's disease, strictures, sinuses, and fistulas. So this is the picture that was given in your radiology lecture. As you can see here, we have a stricture in the terminal ileum here as well. So this is a classical sign that is seen in Crohn's disease. So Crohn's disease, as I said, usually affects the terminal ileum first, affects any age. However, males more. And the ulcers are transmural. Please remember, they're transmural. In ulcerative colitis, as you can see here, we have the pseudopolyposis and the lead pipe appearance. So pseudopolyposis is the polypoidal elevation of residual healthy mucosa between the ulcerated mucosa. So we have ulcerated mucosa, and then we have the elevation of the residual mucosa. In the early phases, there is normal mucosa with some abnormal mucosa, but this is how it progresses. And this is the lead pipe appearance due to the narrowing and rigidity of the colon due to the spasm and hypertrophy. If untreated in late stages, it can become, the colon can become with no hostra. So fibrosis is going to take over. So again, going back to volvulus, because it's mentioned again in your radiology lectures, so it's a good review. Sigmoid volvulus, it's more in the left upper quadrant or left lower quadrant, and the cecal volvulus is in the right lower quadrant. So the sigmoid looks like a coffee bean or an inverted U sign. The cecal volvulus is like kidney shape. Volvulus is basically the rotation of the bowel around its mesentery or axis, abnormal gastro on X-ray. Patients present with obstruction. If it's not relieved, it can lead to gangrene. Next, so this is the same, cecal volvulus. Again, this is the kidney shape. As you can see, cecal volvulus would have shadows on the left with no shadows on the right. So here we have the shadows on the left. Hostral patterns, folds are seen in the cecum volvulus because the sigmoid does not have hostra. This is the sigmoid volvulus. Again, this is the coffee bean sign, inverted U sign, would have an inverted U or bean shape, and normal cecum shows shadows on the right. Okay, so this picture is also important, colonic diverticular disease. So it's basically benign. It happens when there is diverticula or protrusions, small protrusions out of the colon, so outpouching of the mucosa. I don't know why that has my name over here anyways. So outpouching of the mucosa, usually more in the distal colon, more in older ages, and it's mainly due to constipation. Here we have diverticulitis, which is a complication of diverticular disease. So here we only have diverticular disease, they're only outpouching. However, here they are inflamed. And how can we tell? There is air that is outside the bowel. So air outside the bowel shows that there is a chronic inflammation, and this can cause tenderness on the left side. So how I used to solve these scenarios is that you're going to get a basic appendicitis scenario. However, it's going to be on the left, not on the right. It will most likely be diverticulitis. So what we do for these patients is that we usually give antibiotics and liquid diet. Next, we have complications of diverticular disease. Okay, this is a mistake. معلش. Uh, so those are some complications of the diverticular disease. As you can see here, we have the strictures. Next, we have ischemic colitis. This is very important. Ischemic colitis is when there is ischemia of the colon. So you can see that some parts of the intestine are non-enhancing. So some are enhancing and some here are non-enhancing. The ileum and ascending colon are non-enhancing while the jejunum is enhancing normally. And this is due to a superior mesenteric artery block. So just know that this picture shows ischemic colitis in case it comes. These pictures, we talked about them before. This is a porcelain gallbladder. Again, this is an enlarged gallbladder due to the chronic inflammation of the gallbladder. So in radiology, guys, just remember the picture. Okay, just memorize the picture. It's going to come as it is, either in MCQs or in OSPE. So again, enlarged calcified gallbladder wall from chronic cholecystitis. Normal gallbladder is not visible in X-ray unless its wall is calcified or has stones. Okay, so this is a fatty liver or steatosis, dark liver, low attenuation. Why? Because of the fats. So there is dyslipidemia and abnormal lipid profile usually, and it has benign fatty infiltration. Of course, there is signs of hepatomegaly as well. The liver is enlarged. Here we have depositional disorder. So unlike this liver, which has low attenuation or looks dark, this liver over here is bright, and this is due to the iron deposition. So it has bright liver on CT without contrast due to the iron deposition, which is enhancing, and this is seen in hereditary hemochromatosis, for example, or storage diseases. So if this picture comes to you with an enhancing liver, think hemochromatosis or glycogen storage disease. Next, we have the hydatid cysts in the liver. So basically, this is an infection with Echinococcus granulosus. What this bacteria does is that it causes cysts in the liver. It could be a single cyst or multiple cysts. So it can also cause chronic calcified cysts. So this is a single cyst with a chronic calcified cyst, and those are multiple cysts. So if you saw this picture, think hydatid cysts in the liver due to Echinococcus granulosus. Next, we have hepatic adenoma. So it's a benign solid lesion. It's associated with contraceptives. If you guys remember, we did talk about this in a gross picture. It's more common in females, and it's related to contraceptives, as we said. It sometimes might rupture and cause subcapsular hemorrhage. Next, we have the focal nodular hyperplasia. And this was the one with the central scar. Second most common benign tumor in the liver after hemangiomas, enhancement of the arterial phase. So this is the central scar, as you can see, focal nodular hyperplasia. It's a benign solid lesion. Next, we have the acute necrotizing pancreatitis. This is very important to you guys. So as you can see here, we have complete necrosis of the pancreas. This is a pancreatic pseudocyst, which is a complication of pancreatitis. And again, here we have partial necrosis. Still part of the pancreas is working normally. So these pictures show acute necrotizing pancreatitis. Next, we have chronic pancreatitis. How do I know this is chronic? Because there is calcification. Whenever you see calcifications, either on a CT scan or on an X-ray, so this means that this is chronic pancreatitis, maybe due to recurrent attacks of acute pancreatitis, like from alcohol or from gallstones. So again, this is chronic pancreatitis. More pictures that were mentioned in your radiology lectures. And here, I don't know if this is important, however, it just shows a contrast. If this happens in a patient, when you give contrast and this happens, so contrast swallow is contraindicated if there is aspiration. So you should stop the procedure if this happens. So this is a sign of aspiration, and it shows that you should stop the procedure. This is our final checkpoint. We're just going to go through 2 of your lab medicine lectures real quick. Inshallah, they're going to be really easy. So let's start with the LFTs lecture. So your doctor divided the LFTs into 3 types. So we have group 1, which are the markers of hepatocellular injuries. Those include the ALT and AST. Group 2 are markers of cholestasis. Those include the ALP and GGT. Group 3, markers of liver dysfunction. Those include bilirubin, total protein, and the prothrombin time. So for group 1, as I said, ALT and AST. ALT is more specific for liver diseases than AST. If AST is high, while ALT is normal, you think extrahepatic, like muscles. In liver disease, ALT is more than AST, except in alcoholic liver disease, where the AST is more than ALT. And if you guys remember, we said that it should be 2 times. So ALT is more specific for liver disease. So if you have high AST and the ALT is normal, so we don't think liver, right? Because ALT is more sensitive. We're going to think extrahepatic, including muscles. Usually in liver disease, ALT should be higher than AST, except in alcoholic liver disease. So AST to ALT ratio less than 1, this is the normal. If the AST to ALT ratio is more than 2, so this is alcoholic liver disease. If the ALT more commonly, or the AST is more than 1,000, this means that there is a liver injury. It could be ischemic hepatitis, acetaminophen overdose, and so on. Next, we have group 2, which are the markers of cholestasis, ALP, and GGT. So these are cholestatic. So increase in AST or ALT with 3 times increase in ALP. So whenever there is a cholestasis, there would be an increase in AST and ALT. However, ALP would be high as well. High ALP and normal GGT means extrahepatic, like bone, osteoblastic activity. If there is a sudden increase in both, if the increase was very sudden, but this is most likely a hepatocellular carcinoma. GGT alone is increased in alcohol. So again, if we have high ALP alone, for this is extrahepatic, like bone. High GGT alone, for this is alcohol. If we have a sudden increase in both, for this is hepatocellular carcinoma. However, if the hepatocellular enzymes AST and ALT are high with 3 times increase in the ALP, for this is cholestatic. Okay? Third, we have the markers of liver dysfunction, which are bilirubin, total protein, and prothrombin, which are basically anything that the liver is producing. So let's go through the types of jaundice or the bilirubin production. My colleague that is covering the biochemistry crash course will, I'm pretty sure they did a good job explaining the bilirubin metabolism. So I'm just going to go briefly about the subtypes or the classes. So we have the prehepatic or the hemolytic. Those are basically going to have elevated unconjugated bilirubin in the blood. The hepatic or hepatocellular are going to have elevated conjugated and unconjugated bilirubin. The post-hepatic, they're going to have elevated conjugated bilirubin. That's the most important thing that I want you to take from this table. Okay, so if we have elevated unconjugated bilirubin, for this is prehepatic, so most likely hemolytic, something in the blood, right? If it's hepatic or hepatocellular, it could be both elevated unconjugated and conjugated. Okay, so here in the prehepatic, urine bilirubin will be absent. Hepatocellular and obstructive or post-hepatic, we are going to have elevated conjugated bilirubin in the urine. So whenever the urine has conjugated bilirubin, but this is either hepatic or post-hepatic. If it has unconjugated bilirubin, for this is prehepatic, okay? Stool color, if the stool color was dark, for this is prehepatic. If it was pale, for this is hepatic. Very pale, this is post-hepatic. Stool cercobilin is only increased in hemolytic anemia or prehepatic. In hepatic and post-hepatic, the stool cercobilin is going to be decreased. So let's do some practice. Here, if a patient has jaundice and anemia and an increase in unconjugated bilirubin. So when there is increase in unconjugated bilirubin, we said that this is going to be prehepatic or hemolytic anemia, right? So hemolytic jaundice. A patient has jaundice, increased urine conjugated bilirubin, unconjugated. No, sorry. So we have jaundice, unconjugated bilirubin, and conjugated. So both are increased, and we have increase in AST, increase in ALT, and also a bit of increase of ALP. But this is most likely a hepatocellular jaundice, right? Because it is hepatic, because of the mix of the bilirubin. The liver enzymes are very high, and we have some degree of increase of ALP, but this is most likely hepatic. Finally, we have jaundice, increase in the unconjugated bilirubin and conjugated bilirubin. Okay, increased AST and ALT, but not much. What's most likely increased is the ALP and the GGT. So we have a very high ALP and GGT, but this is most likely post-hepatic or obstructive jaundice, something that is obstructing the biliary tract. Something that was mentioned in your slides is the neonatal jaundice. So sometimes jaundice can be physiological in neonates, and this is due to increased production from breakdown of red blood cells. So basically, sometimes we have increased unconjugated hyperbilirubinemia in neonates because of the increased production from breakdown of red blood cells and decreased excretion because of the immaturity of hepatic bilirubin. When do I say that this is pathological? When it is due to dehydration, increased hemolysis, the patient has G6PD deficiency. You basically wait for for 14 days. 14 days is the cutoff. If the patient still has jaundice, you should check them up. Okay, so one complication is kernicterus or bilirubin encephalopathy. High bilirubin can cross the blood-brain barrier and leads to lethargy, poor sucking, and convulsions. That's why screening is very important. Now, talking about group 3 again, so we talked about the bilirubin. Let's talk about the other stuff that the liver produces. So we have albumin. Albumin is usually between 3.5 to 4.5, and it's produced in the liver. In liver cirrhosis and chronic liver disease, albumin level is going to decrease because the liver is not working well, right? Blood clotting factors are going to decrease as well, causing a prolonged PT time. So these are some cases that were mentioned in the slide. So a GP was called to see a 21-year-old female student who had been complaining of flu-like illness. On examining the patient, the doctor found that she had recently returned from a long holiday. Okay, a sample of urine appeared dark, so the urine is dark, and bilirubin was present, and urobilinogen was increased. Okay, so we have bilirubin in the urine. A blood sample was taken for liver function test. So what did they see? The albumin was normal, ALP was high. ALT was high, bilirubin is high, and the GGT activity is high. So what is the most likely diagnosis? Since there is bilirubin in the urine, so this is conjugated hyperbilirubinemia, right? Elevated serum ALT and increased urinary urobilinogen. This shows that the jaundice is hepatocellular in origin because the liver enzyme is high. The serum ALP and GGT shows that there is also some degree of intrahepatic cholestasis. So this is basically hepatitis. So it is a hepatocellular in origin due to an infective agent, and they saw that the titers of hepatitis A were increased. This patient over here is complaining of loss of weight, tiredness, and loss of appetite. He also stated that he had been passing dark urine for some time and that his stools were quite pale. So what was, if you guys remember, what was the one with pale stools? And the man came also with jaundice. The results of the liver function tests were as shown. So albumin is low, ALP is very high, ALT is high, but not that much. Bilirubin is also high, GGT activity is very high. So you could tell that this is kind of obstructive, right? It's not hepatocellular in origin. The pale stools, presence of bilirubin, and lack of urobilinogen in the urine, accompanied by high serum ALP and GGT, suggest that the patient has cholestatic jaundice. The abdominal mass and positive fecal occult blood suggest that tumor of the biliary tract or the pancreas may be responsible. When they did an ultrasound, they did see a dilated intrahepatic and extrahepatic ducts showing a tumor at the head of the pancreas that was obstructing the tracts. Now for the final lecture, which is the nature of tumor markers. So tumor markers can be of different nature. Okay, so some are enzymes or isoenzymes, including the ALP and the PSA. So those are produced by tumor cells or released due to tumor activity. Some are hormones secreted by hormonally active tumors, including the calcitonin. Some are oncofetal antigens, so they're basically normally expressed during fetal life and re-expressed in malignancy. Those include the AFP and the CEA. Some are carbohydrate antigens that are secreted glycoproteins recognized by monoclonal antibodies. Some are hormone receptors expressed on tumor cells and used for prognosis and treatment selection. So examples are estrogen and progesterone receptors. Some are due to genetic alterations like BRCA1 and BRCA2. Okay, so let's talk about what's the most important ones. So the doctor emphasized on these. Number one is the ALP, which is increased in liver cancer. Second is PSA, which is increased in prostate cancer. However, PSA is not used for screening. It's used in monitoring the treatment of prostate cancer. One thing to note is that the ratio between free and total PSA is a reliable marker for differentiation between prostatic cancer from benign prostatic hyperplasia. Okay, then for the hormones, we have the calcitonin, which increases in medullary thyroid cancer, and then we have the oncofetal antigens, including the AFP or the alpha fetoprotein, that increases in hepatocellular carcinoma and non-seminimatous germ cell tumors. They could also be increased in pregnancy, chronic liver diseases, so it does not have to be a tumor marker, right? Next, we have the CEA, which is most likely seen in colorectal, gastrointestinal, lung, and breast carcinoma. This is not recommended for screening because it's not sensitive. Next, we have the carbohydrate antigens. We have CA15-3, which is seen in breast cancer, CA125, seen in ovarian cancer, and CA19-9, which is seen in pancreatic cancer. If you guys remember, we talked about this. Now, one thing to note is that CA125, although it increases in ovarian cancer, it could be high in normal patients. So the doctor provided a scenario where a woman was doing some blood tests and got a high CA125. However, when they did screening like ultrasound and CT scan for the abdomen, they did not find anything on the ovaries. So it just showed that it could be high in normal patients, right? And this is a summary. So alpha-fetoprotein, as we said, testicular and hepatocellular carcinoma. It could be high in cirrhosis, hepatitis, and pregnancy. CA125 in ovarian cancer, CEA in colorectal cancer. PSA in prostate cancer, CA15-3 in breast cancer. We did not mention this. Breast cancer can also have BRCA1 and BRCA2, CA19-9 in pancreatic cancer. So this is a case. A 58-year-old male lecturer presented to his doctor complaining of tiredness, abdominal discomfort, and poor appetite. He had worked in Africa in the past where he had contracted hepatitis B and had become a carrier. Contacted. On examination, he was jaundiced and his liver was enlarged. Urine was positive for both bilirubin and urobilinogen. Okay, so ALP activity is very high. Albumin is borderline normal. ALT is high. Bilirubin is high. GGT activity is high. Alpha fetoprotein is 3,000 when usually it should be 5. So this is a classic presentation of hepatocellular carcinoma. And that's it for my PAL session. I really hope you guys did benefit. If you have any questions, for these are my contact info. This is my phone number and this is my email. Please feel free to contact me if you have any questions, and thank you.